So unlike the previous speakers, I'm going to tell you exactly what to do with diastasis, so don't worry. No, just kidding, I have no idea. Like all of the topics today, there's so much variety, and so I'm going to be borrowing some data from plastic surgery, from physical therapy, some from general surgery, and really the short answer is we don't know the right way to do this. And so we have a lot of expertise in the room today, and I'm hopeful that you can share some of that during our question and answer and kind of some of the case scenarios after this. All right, we'll see. Okay, so these are my disclosures. All right, so talking about diastasis, this is a topic that's really near and dear to my heart, and I think it's just so fascinating that this is such a common thing, and we don't really have a good way of repairing this. And as one of my mentors in my general surgery residency told me, if there's a lot of ways of doing something, it means we haven't found the right way to do it yet. And so I think all of these topics today really highlight that. So, but I think with the explosion of new techniques, particularly in our minimally invasive approaches, and just kind of a new attention on abdominal core health, we're really kind of focusing in on this and narrowing that knowledge gap. All right, so just to make sure we're all on the same page, diastasis recti, separation of the diastasis or of the rectus muscles, and risk factors are pregnancy, particularly pregnancies where women are carrying multiples, when they're carrying large babies to term, small stature of the mother or age 35 or older, and then macrosomia of the baby. We also see this though in postmenopausal women and obese men. And so I'm going to kind of spend this first bit talking about kind of pure diastasis. We'll talk a little bit about hernias in relation to that, but just sort of to set the stage as to why this is important. And so bear with me, like I said, this is that plastic surgery literature that we're talking about. So when we think about diastasis, really there's a lot of ways to describe it, but kind of the most common way that we think about it is by taking measurements 3 centimeters superior to the umbilicus and 2 centimeters inferior. If it's greater than 22 millimeters at the top or greater than 16 at the bottom, that's considered diastatic. And usually we've used the NAHAS classification. And you can see that there. The most common type is type A, which is a result of pregnancy, and that has traditionally been treated with an anterior rectus sheath plication. However, there has been some recent discussion kind of from the general surgery side, and so our European colleagues recently, 2019, offered up this descriptors for how do we describe diastasis when there's a concomitant hernia. And so you can see that over on the right side of the screen here, that this is the language that they propose so that we all have a common way of describing this. And I think this is really key for starting to document what we're seeing, so that we can really study this going forward. We need better studies. They also note the importance of making sure we're commenting on gender, concomitant hernias, previous surgery, number of pregnancies, how they went, multiple births, skin condition, those kinds of things. So why this is important is that the incidence ranges from 33 to 74% after pregnancy. Okay, 1/3 of these patients will continue to experience diastasis after a year postpartum, so they're probably kind of stuck with it at that point. And this can be associated with low back pain and pelvic dysfunction. And if you think about it, if there's almost 4 million live births in the United States each year, this is a lot of women that are dealing with this. And this is not to only focus on women, but this is just one of the main populations that we see this in. Okay, so interestingly, this is from plastic surgery kind of literature, but pain while being seated for 30 minutes or pain limiting the ability to play sports are positive predictors for successful surgery for intervention on diastasis. They also, there's been noted a small association between diastasis recti and pelvic organ prolapse. And then overall, when we look at studies comparing physical therapy approaches versus surgery, surgery results in significantly improved abdominal wall function compared to the non-operative group. It's a little bit of a tricky thing to study, but this is usually done by physical therapists who kind of run these patients through a series of different movements. So I'm going to touch on this a little bit later too, but really kind of our main information as to whether we should deal with diastasis at the time of umbilical hernia repairs comes from this study. And this is a retrospective analysis of 231 adult patients. And they were undergoing elective suture-based repair of hernias that were 2 centimeters or less, primary umbilical or epigastric hernias. And in patients that had an associated rectus diastasis, 29 out of 93 of those had a recurrence, compared with 9 out of 108 who did not have an associated diastasis. They also looked at absorbable versus non-absorbable suture, higher recurrence rate with absorbable suture, and higher recurrence rate with obesity over 35, as you'd expect. So again, purely talking about just diastasis, not hernias associated with them that they know of at the time of operation. The largest RCT on diastasis recti was done by Emanuelson, and he looked at 89 patients with diastasis. And they did a plication of 2 layers using a 2O barred polydiaxone suture. They looked at repair with retromuscular polypropylene mesh and a supervised exercise program. Median BMI was 23, which is amazing, all symptomatic and all non-smokers. And really there was no difference, so overall surgery seemed to be better, and there was no difference in just the suture plication versus the mesh reinforcement. So out of that, they recommended just the suture plication. Emanuelson et al. Did another study looking at 52 patients with a 1-year follow-up who showed no recurrence, and they assessed secondary outcomes at a median of 5 years. And really the thing that I'm going to show you a couple studies like this, but really what comes out over and over again when we think about diastasis is quality of life improvement. So it's very difficult to study actual functional changes, but across the board, these studies show significant improvement in quality of life. Here's another similar one here, also with a double row plication with absorbable Quill 2O sutures. And interestingly, in this group, 45 out of 60 patients had a concomitant fascial defect that was identified pre-op, even though that wasn't their primary complaint. And 13% of those remaining had another one that was diagnosed during surgery for their diastasis plication. So I think that's the other thing, is sometimes, as I think we've probably all seen this, there are occult hernias hiding in there that we find when we're addressing the diastasis. And so here again, kind of a busy slide, but just looking at quality of life improvement. And so this one was interesting. They did a short form 36 questionnaire, and in these Swedish females, the ones who had undergone diastasis plication had similar or higher levels than normal of Swedish females for their quality of life. So they were overjoyed with it. But they also performed better and endured their exercise programs a little bit differently, so they had them followed with physical therapists. Okay, uh-oh. Next slide, please. Okay, so getting back to that study that we talked about a little bit before with the primary closure of these under 2 centimeter umbilical hernias in the presence of diastasis. So there was a 31 versus 8% recurrence rate when there was a concomitant diastasis. And so the recommendations from that study showed primary closure with non-absorbable suture and thinking about mesh repair in patients who have a umbilical hernia around 2 centimeters or more with a coexisting diastasis recti. Okay, you with me so far? We're gonna start getting into general surgery a little bit more here. Can you advance the slide? Okay, all right, so there's recently been a little bit of a change in mindset for diastasis, and I think this comes down to that explosion of techniques that we have. So our traditional way of thinking was of diastasis was that there's no real risk that we worry about with hernias. So there's no risk of strangulation or incarceration as long as there's no hidden hernia defect in there. And so it's largely been considered cosmetic and kind of pushed over to the plastic surgeons. But as our minimally invasive techniques have exploded, we really have different ways of approaching this that kind of minimize some of those risk factors that we had before. Previously, if our only approach was an open abdominoplasty, we would worry about seroma rates of 15.4%, infection of 1 to almost 4%, skin necrosis of 3 to 4.4%, tobacco tripling that risk, of course, and hematoma. And so sometimes that risk-benefit ratio didn't make sense, but as we've had more minimally invasive options, I think that balance is starting to shift a little bit. Okay, so the other thing is we always fear, can we make things worse? You know, no good deed goes unpunished. We worry about seesawing of suture through fascia under tension, creating Swiss cheese defects or worse, large hernia defects. And then when you really think about adding mesh in there, then you're adding a foreign body and the risks that are associated with that. And so I think that's kind of the mental gymnastics we've been going through. But for me, so when they come to me, they're usually patients that do have diastasis, but also a hernia that's been identified. And in that case, really, I'm already planning on putting mesh in for the great majority of these patients. I'm almost 40, I can't see this. It takes, while we're there, it takes less time. You know, we're already in that space, especially if we're doing this robotically or laparoscopically. It doesn't take that much more time to just kind of placate that diastasis. And I think the question for me is, if we are addressing that diastasis, is that long-term going to reduce our recurrence rates? Or not so much recurrence, but if we're stitching through that diastasis at the apical portion, are we creating new hernias down the road? So for me, if there's diastasis and a hernia, I'm usually going to fix both. Okay, so like anything, patient selection is so important, so really looking for that BMI of 35 or below. And I would just put a little bit of a separate plug in. I see a lot of patients that have been told by their surgeons that they need to lose weight and come back when they're done. And I would just really encourage you to partner with your patients a little bit more than that. Help link them in with your bariatric medicine programs, talk with your bariatric surgeons, do something, just spending a little bit of time with them to kind of say, I'm on your side, I'm trying to help you do this. It's amazing what they can actually get done. If these patients have excess skin, these are probably a better patient for your plastic surgeon colleague and would be better served by an open abdominoplasty with skin excision and with that diastasis plication and hernia repair at the same time. If it's just an isolated diastasis and a hernia, I would strongly consider an MIS approach. Next slide, please. Okay, so for open approaches, we have lots of options. Traditional abdominoplasty with diastasis plication, usually 2 layers, include that primary fascial closure of the hernia defect, and then plus or minus on the mesh. The studies are all over the place on that, so I don't think we have clear indications. And if you do place mesh, you can do that retrorectus, you can do it underlay, you can do it onlay. We'll talk about that a little bit. I wanted to touch a little bit on the Milos, which is the mini or less open sublay, which more of our European colleagues are familiar with. But that's kind of it's like a little mini, slightly larger than just the traditional incision we do for a small open umbilical hernia repair that uses a lighted retractor and allows for diastasis plication. And then the other thing to kind of consider, especially when you're doing this open, is just where are you going to fixate if you do end up putting mesh? How are you going to do that around the diastatic portion, and maybe be thoughtful about where you're putting your stitches so you're not just plowing that right through the most attenuated portion. And there's been a lot of interesting studies or kind of reports of using self-gripping mesh for these, using glue. People are really trying to think outside the box on how to address the hernia and then also be respectful of the diastasis, even when it's closed. Okay, next slide, please. All right, so just a little touch on that Milos. This is a great paper, and Wolfgang Reinpold and Reinhard Bittner are just doing some of the most amazing studies on this. And these are cases that are dealing with open umbilical hernias and then also some diastasis. So there's this study, but I'm going to talk about the laparoscopic one a little bit more. But they're really kind of trying to figure this out. So just kind of the long and the short of it for the open approach, take-home points. And this is after looking at all the research that's out there. And then also, if you guys are members of the International Hernia Collaboration, there's been some really wonderful discussions. I've read everything on there that's about diastasis. And these are the take-home points. So if you are doing an open approach for diastasis, use a permanent suture or a long-acting resorbable. You want to close the diastasis without resisting the temptation to kind of continue to travel more and more lateral as that rolls in. So just keep it kind of right down the middle. Most would recommend a double layer repair. That seems to have a lower recurrence rate. And think about doing the xiphoid to the pubis if you're really thinking about a really good cosmetic result. Okay, minimally invasive techniques. This is a great technique, or these techniques, I should say, are wonderful if there's not a lot of skin that you're going to need to deal with. There are no prospective studies, to my knowledge, comparing open versus minimally invasive techniques. So if somebody knows about it, I want to know about it. And this is kind of a natural evolution because there is usually a strong cosmetic component to the diastasis, and so making it minimally invasive, that really just kind of goes hand in hand. All right, so Lots of varieties for this one as well. There's less data, even less data, I should say, for minimally invasive approaches, and the options are endless. There's the e-Melos, which we'll talk about, ETEP, which was popularized by Deas in 2012, the ETEP Reef-Stopa, popularized by Beliansky, TAP, which we've seen a wonderful example of earlier, retrorectus repairs, and SCOLA. You can use mesh, you can not use mesh, you can just do primary suture closure. And really this is one of the things that came up on the International Hernia Collaboration. And there was kind of a general trend, I would say, with most surgeons. If there's a smaller diastasis and a really small umbilical hernia, primary suture closure for that seemed to be what the majority of people are doing. But then when it started to get to kind of that 3 to 4 centimeter diastasis or more, particularly if that 3 was infraumbilical, 4 supraumbilical, then that would kind of support mesh placement. Again, thinking about plicating xiphoid to pubis and incorporating the hernia with that plication. Okay, so just to touch on this one a little bit more. So this is, I figured we'd have more discussions kind of about ETEP and the ETEP Reef-Stopa. These are a little bit less common, I think, in the United States, so I just wanted to highlight these a little bit. So this study looked at 520 primary umbilical and 554 epigastric e-Melos operations, and they did 1-year follow-up. Concomitant rectus diastasis was treated in 18.3% and 14.1%, and those were addressed with primary plication during it, and they had great results. And so you can see those here. This is really one of the only studies that is really mentioning hernias plus diastasis, how they're managing it, and following those results. So I commend these guys. They're really kind of leading the charge. A few words about SCOLA, and I don't know if Flavio's here somewhere, but this has been another really innovative approach for a subcutaneous on-lay laparoscopic approach to diastasis recti. And so these are from a paper from 2018, just to kind of describe how this approach goes. So it's all subcutaneous. So it's a laparoscopic approach, but it's all subcutaneous, and there's plication of, kind of allowing for broad plication really all the way up to the xiphoid, and addressing a hernia through this space. And that's had great results too. It's an on-lay mesh, which is a little bit different than some of the other studies that we've seen, but really just lots of different techniques. So I love the creativity. Oops. All right. For me personally, my go-to, I do primarily robotics, and so I like to do a robotic transabdominal preperitoneal approach, exactly as performed by Dr. Coker in her previous talk. I drop the peritoneum down to really make sure that I'm exposing the fascia, and when I do plicate the diastasis, I first run my suture down, and then before I finish, I really drop the pressure low, and I go back and tighten to make sure that we're not gonna have gaps when that carbon dioxide is gone. I use something that's described as the Venetian blind technique, which I'll show you on the next slide. I generally use a non-absorbable suture, and for the majority of patients, if I'm there for a hernia, I'm gonna be putting in a mesh in that preperitoneal position. The only people I don't do that on are postpartum women that are in great shape, have like a 1 centimeter umbilical hernia. Then sometimes I'll just plicate their small diastasis and that hernia primarily. This is the Venetian blind technique, and so you're taking multiple bites kind of through that. You're going through posterior fascia, kind of trying to grab what's left of, or the remnants of the linea alba, trying to go through the anterior fascia, and then plicating the sac down. So this is what I usually end up doing. It does leave them with a little bit of a ridge right after surgery, but that always softens out. So some considerations post-op: when you do add that diastasis repair to the umbilical hernia repair, they're gonna have a lot more pain. Really, it's that's the part that is painful. Most people don't have much, don't seem to be too bothered by the umbilical hernia repair part. So for my patients, I use muscle relaxants like a low-dose Flexeril on a scheduled basis after surgery. There's some discussion in the literature about doing Botox before surgery for those. I don't do that for these particular patients myself, but I do tap blocks with Exparel during surgery. And then, like I mentioned, they will feel a ridge on the midline for a little while, but that usually softens out. If it's a larger diastasis, they're gonna have a big ridge, and so for those patients, I would do it open, just purely for that cosmetic result there. And so just kind of in closing, my case for repair is really thinking about, it is gonna take you a little bit more time in the operating room. You're probably not gonna be reimbursed for it too well, but when we think about our patients kind of as the whole person in the context of their whole life, if we can give them this quality of life improvement, virtually all studies that look at this show an improved quality of life. We're thinking more and more about abdominal core health and reestablishing the natural position of the rectus muscle for better functioning. This is really difficult to study, but I think we can all agree that we've seen some that seem to act like hernias kind of functionally. Also looking here, spending this time, you may identify occult hernias, which can prevent kind of recurrences down the road that maybe weren't actually recurrences, but just missed hernias. We have more minimally invasive options, and we have option for mesh placement while we're there and really support these weakened abdominal walls. So my last slide, so William Worrell Mayo, I would say this falls into the category of many things that he would say this about. This topic has been left open for further thought and research. So this is a call to action. Let's see what we can all come up with. Thank you.